Welcome back. This is Ian Bodford.
And Liang Lu.
And this is the Clinical Correlation.
Today we present
And that's all, folks.
Part 2.
Let's start by remembering the case of the hypotensive patient with abdominal pain and a positive pregnancy test at home. Ectopic pregnancy should be on the differential in any female patient of reproductive age with abdominal pain or vaginal bleeding.
Several risk factors exist for ectopic pregnancies, but keep in mind that no risk factors are present in over half of all cases.
The first step in management is to assess for shock and resuscitate as needed.
Obtain a beta HCG and perform a pelvic ultrasound. If no IUP is seen and the HCG is above 1500, an ectopic pregnancy should be assumed and OB-GYN should be consulted.
Unstable ectopic pregnancy should go to the OR for laparoscopic removal. If the patient is stable and has no contraindications, methotrexate can be given in coordination with OB-GYN.
Speaking of pregnant patients, in the case of our 35-year-old involved in an MVC, resuscitation is similar to other trauma patients, with the exception of a few key anatomic and physiologic changes. Cardiac output increases, heart rate increases, and blood pressure falls during a normal pregnancy.
Additionally, the gravid uterus can compress the IVC and decrease cardiac output in the supine position. There is decreased gastric motility and emptying time, which can lead to aspiration during intubation.
Remember that fetal survival depends on maternal integrity. Vasopressors can restrict blood flow to the uterus, but allowing the mother to be in a state of shock vastly increases fetal mortality. Be concerned for pregnancy-related injuries, including placental abruption and uterine rupture. Give ROGAM when appropriate.
In the worst-case scenario, be prepared to perform a perimortem C-section.
Your pregnant female is stable, but now let's focus on her C-spine.
Fractures of the spine can be stable or unstable. Use the mnemonic Jefferson bit off a hangman's thumb to remind you of the unstable fractures.
Jefferson is for a Jefferson fracture, which is a C1 burst fracture.
BID is for bilateral cervical facet dislocation.
OFF is for odontoid fracture, and specifically type 2 and 3 are unstable.
A is for atlanto-occipital dissociation and fracture, which is also known as an internal decapitation. The injury results in a disruption of the stabilizing ligaments between the occiput and the C1 vertebral body.
Hangman's is for hangman's fracture, in which there is a bilateral C2 pedicle fracture resulting in anterior displacement of C2 on C3.
And thumb is for teardrop fracture, which results in a displacement of a teardrop-shaped fragment of the anterior-inferior portion of the superior vertebrae with posterior displacement of the vertebral body and disruption of the posterior longitudinal ligament.
Compartment syndrome also can occur in traumatic injuries. It is an increased pressure in one of the body's compartments that results in decreased perfusion of that compartment's contents, including muscles, nerves, and bones. Remember that all of the extremities contain compartments, even the hands, feet, and buttocks.
We all learned the 5 Ps in medical school for compartment syndrome, but sensitivity for these are low, so keep a high index of suspicion. A Stryker needle can be used to determine the pressure of the compartments. Normal pressures are typically less than 10 millimeters of mercury.
Delta pressures are better for predicting elevated pressures. It is the diastolic blood pressure minus the compartment pressure. A delta pressure of less than 30 milligrams of mercury is highly suggestive of compartment syndrome.
Treatment is an emergent fasciotomy since irreversible damage can occur within 8 hours.
Be on the lookout for hematuria following abdominal trauma. Hematuria in trauma can be microscopic or macroscopic. Generally speaking, the greater the degree of hematuria, the greater the risk of significant intra-abdominal injury. However, hematuria is not necessarily seen in some renal or renovascular injuries.
Penetrating trauma in the abdomen with hematuria generally needs surgical exploration. In blunt trauma, it depends on the severity of the hematuria and the stability of the patient.
A stable adult patient with only microscopic hematuria requires no further imaging and can follow up with their PCP for a repeat UA in 1 week. Patients with gross hematuria or who are unstable with microscopic hematuria require a CT abdomen pelvis with IV contrast and a CT cystogram. Is your bleeding patient on a blood thinner? Depending on the type of blood thinner and the injury, it might need to be reversed.
In the case of warfarin, decision to reverse and to what extent depends on the extent of the bleeding, the INR, and the reason for anticoagulation. Regardless of the INR, if a life-threatening bleed is present, warfarin should be held and IV vitamin K should be given. 4-factor PCC or fresh frozen plasma can also be given depending on the clinical urgency.
Protamine sulfate is used to reverse heparin or low molecular weight heparins. Reversal of factor Xa inhibitors is complicated. A number of reversal agents are in various stages of FDA approval, including idarucizumab, siraparantag, and andexanet alpha.
The first step in treating a snake bite is determining whether it is venomous or not. In the U.S., we have 2 families of venomous snakes, the critollids and the lapids.
Crotalid venom causes local tissue injury, hemolysis, and coagulopathy. Absence of any of this 8 hours after a bite indicates a dry bite, and the patient can be discharged.
Treatment includes local wound care, tetanus update, removal of all jewelry, which can become stuck due to swelling, and elevate and immobilizing the limb. Be wary about compartment syndrome. The antivenom for crotalid bites is Crofab.
Elapid venom does not usually cause much local tissue damage, but a consumptive coagulopathy similar to DIC with associated renal failure and hypovolemic shock can occur. Neurotoxicity due to the venom can affect the cranial nerves and can cause respiratory depression. All elapid bites need to receive antivenom. However, it can be hard to find in some regions due to the rarity of the bites. All patients require admission, even if symptom-free.
We discussed many environmental exposure injuries this year on the clinical correlation. First, we will go over diving-related injuries and specifically dysbarism and breathing gas-related problems.
Injuries occur during both descent and ascent. Barotrauma of descent is known as squeeze, and the ears and sinuses are most likely to be affected. Nitrogen narcosis during descent can result in hallucinations and loss of consciousness. Treatment is ascent.
Decompression sickness, also known as the bends, occurs with ascent. Barotrauma of ascent is essentially the opposite of squeeze. As the volume of gas increases with ascent, the teeth, GI tract, and lungs can be affected. In burst lung, the compressed gas can dissect the surrounding tissues, resulting in pneumomediastinum or pneumothorax.
The most feared complication of burst lung is an air embolism. Cardiac arrest can occur from an air emboli in the coronary arteries. However, the brain is the most commonly affected organ and presents as an acute stroke. Think air embolism in the diver with sudden loss of consciousness immediately after ascent. Treatment is recompression in a hyperbaric chamber as soon as possible.
The next environmental exposures we discussed were high-altitude illnesses. Acute mountain sickness, or AMS, reflects a lack of acclimatization. Susceptibility to the condition is not related to physical fitness. Symptoms usually occur at altitudes above 8,000 feet.
Life-threatening conditions associated with altitude include high-altitude cerebral edema, or HACE, and high-altitude pulmonary edema, or HAPE.
Symptoms of HACE include severe headaches, confusion, ataxia, drowsiness, stupor, and coma.
HAPE is characterized by decreased exercise capacity, dry cough, cyanosis, dyspnea at rest, and pink, frothy sputum.
Mainstay of treatment for both is rapid descent. Oxygen, portable hyperbaric chamber therapy, and dexamethasone can also help. A number of pharmacologic measures can be used to reduce pulmonary arterial pressure as well.
Our last environmental exposure illness video was on heat-related emergencies.
We discussed heat rash, heat edema, heat syncope, heat cramps, heat exhaustion, and heat stroke, with the last two being the most serious.
Heat stroke is at the extreme end of the heat-related emergency spectrum. It is fatal if not treated and has a 30% mortality rate even if treated. The patient's core temperature will be elevated, usually greater than 40 degrees, and they will also have CNS derangements, ranging from altered mental status to ataxia to seizures, which differentiates the condition from heat exhaustion.
Remove the patient from the hot environment and initiate cooling techniques as soon as possible. Cold water immersion is the most effective cooling technique. Evaporative cooling measures are easier to apply in the emergency department. This involves spraying cold water and having fans directed at the patient. It is slower than cold water immersion, but also does not interfere with resuscitative efforts.
Dental emergencies are a common presentation to the ED, so learning the lingo is a must.
Numerous injuries can occur to the teeth, including concussion, subluxation, luxation, intrusion, extrusion, and avulsion.
An avulsed tooth should be stored in milk or a specialized product called Hank's Balanced Salt Solution. In the event that saline or milk is unavailable and the patient is conscious, store the tooth in the patient's mouth at the vestibule between the gingiva and the buccal mucosa.
To reposition an avulsed tooth, rinse the socket with saline to remove loose debris. Irrigate the tooth, push the tooth into the alveolus with firm pressure until it is at the level with the adjacent teeth, and splint the tooth in place using wire and Dermabond. Prescribe a soft diet, 1-week course of penicillin VK or clindamycin, and arrange for dental follow-up.
Tooth fractures are divided into 3 categories based on the depth of injury and the tooth layer involved. They can be referred to based off the Ellis classification. Ellis Class 1 is a fracture involving the enamel, Class 2 is a fracture involving dentin, and Class 3 is a fracture involving the pulp.
Avulsed teeth can potentially be swallowed, and generally, it and most objects will pass through the GI tract spontaneously. However, up to 20% will require some type of intervention, with 1% requiring surgery. The object can get stuck anywhere in the tract as there are several narrow spaces.
On X-ray, coins in the esophagus will present their face on AP or PA view. If the coin is in the trachea, it will present its face on the lateral view.
Button batteries have the classic double ring sign, or target sign, on X-ray, and are a true emergency as they can lead to injury of the mucosa and perforation in as little as 6 hours.
Urgent endoscopy is required in several situations. These include complete obstruction of the esophagus causing pooling of secretions, ingestion of button batteries, sharp or elongated objects, and multiple foreign bodies, evidence of perforation, presence of the foreign body for greater than 24 hours, and symptoms of airway compromise.
So that's it for this year. Thanks for all the support and watch out for our future endeavors.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLU.
Thanks for listening.